Hi, this is Christian Macari, and I'm addressing this lecture on sinus lift procedures from Beirut, Lebanon. Actually, I'm a senior lecturer at the oral surgery department of the Faculty of Dental Medicine of St. Joseph University in Beirut. And throughout this presentation, I will be talking about both lateral and crested approaches, doing a critical clinical review about those clinical techniques. And before I start, I would like to thank Dental XP for giving me the opportunity to post this lecture on their website. As a clinician, whenever we are in front of a situation like this, a patient with an edentulous posterior maxilla, we're always aware that there is what we call the phenomenon of pneumatization of the maxillary sinus that we can see here clinically with this convex aspect of the buccal bone, and we can confirm it radiographically by seeing this huge sinus and this very low residual bone height that will allow a little amount of bone for placement of dental implants. This is why many years ago some authors try to describe or try to find some alternative to sinus lift procedures, like the pterygoid implants, for example, or some tilted implant, and this is a trend that is still available today, like in this study by Aparicio and co-workers, who showed high and predictable result of those tilted implants, or the new concept of all-on-4 implants described by Paulo Malo that shows that the placement of tilted implants anterior to the sinus, the maxillary sinus, can be done successfully. Another option would be the placement of short implants, especially when those implants are wide diameter implants. And the literature showed a high success rate of such procedures. Like, for example, in a case like this one, when we have a residual bone height of 8 millimeters below the sinus with a very wide crest in the buccal palatal direction, we can place a short 6 by 8 millimeter implant as this one, and this can be restored, and we can see the very predictable result 5 years afterwards. But if we want to keep on the focus of this presentation, I will be talking in the first part of this presentation about lateral sinus lift procedures. The lateral approach was actually described by Tatum in 1977, and then it was published by Boyne and James in 1980. And this technique consists of raising a flap in order to access the bone that covers the sinus, the thin palatal buccal bone, and then with the use of a drill instruments or with the use of some piezoelectric instruments, we can access the Schneiderian membrane by drilling this bone. And once we've accessed this membrane, we have to lift it. And in order to lift this membrane properly, we have to do what we call the desiccation of the Schneiderian membrane. This is why we use some curettes, like in this case, in order to separate the membrane from the bone. And then we can use some angulated curettes, sinus lifting curettes, in order to access it mesially, distally, and go also to the floor of the sinus. And this whole process should allow us to lift completely the membrane and access the palatal bone that we see here. This is the palatal wall of the sinus. And once we've done this successful lifting of the Schneiderian membrane, we can put our bone grafting material, and this will allow us to pack the sinus completely. And if you see on this radiograph the amount of bone that can be packed into a sinus. With a sinus with a residual bone of 2 to 3 millimeters, we can go with huge quantities of bone graft that will allow in the future to place proper implants. But the first question that arises is, what's the decision to take clinically? When to place implant immediately with sinus graft procedures, and when to wait and delay our implant placement? This is why I will go back to this report of the Sinus Consensus Conference that was done in 1996. And this is one of the most important consensus conferences that were done on this subject by Jensen and co-workers. It was published in the iJomi in 1998. And in this article, they talk about residual bone height and different alternative clinically that should be carried on. Like if we have 4 to 6 millimeter of residual bone height, we should do a lateral approach with grafting and immediate implant placement. And if we had something like 1 to 3 millimeter, we should delay implant placement. So basically the idea is place the implant whenever you can stabilize it and delay the implant placement whenever we don't have enough bone to allow for implant stabilization. If we look at this clinical case, on a panoramic X-ray, we can take an idea of the position of the sinus, and then we should start doing some more examination. The computed tomography exam, like a CBCT or a CT scan, is always very important to do in order to, first of all, rule out any pathologies that may be found inside the sinus. Like in this case, we see that we have some thickening of the membrane, and in this thickening may be due to a chronic inflammation or to a presence of pus or sinusitis. This is why we should rule out any pathology before we place any bone graft into a sinus, because an unhealthy sinus can lead to infection of the biomaterial that was placed. The second thing is to see the presence or the absence of this artery, which is the internal anastomosis of the anterior maxillary artery that goes through the buccal bone of the sinus. And it is always important to try to avoid injuries over this artery, for example. So if we come back to this case and we decide to place 2 implants on the left and 3 implants on the right, it's obvious that this implant cannot be placed immediately because the residual bone height of 1 millimeter will be very difficult in order to achieve a primary stability of our implant. So clinically, we place 2 implants as we planned on the left side, and this is the sinus lift, and those are the indicator pins, and this is to the right thing. So here we perform our sinus lift with 2 implant placement, and this is the sinus lift with 2 implant placement, and we allow for this bone to heal in order to place an implant later on. And if you look at this case radiographically, you can see this was the sinus, and this is the whole grafted bone. And also here you can see the sinus, and this is the whole grafted bone. Later on, we placed the implant that were missing, like an implant in this grafted bone, and we can restore the case. And this is 4 years afterwards. You can see how stable is this case, and especially the bone, it's very well healed, and you can see how the radiographic aspect of this bone shows that it is a very nice and very healthy bone. So in this case, as you can see on this panoramic X-ray, we have an edentulous maxilla in the posterior part of it, and in this left side we see a pneumatized sinus with a residual bone height beneath the sinus that is less than 3 millimeter, as I can say, in the first molar region. So what we decide to do in this case is to perform a sinus lift procedure, place an implant in the premolar region, perform a sinus lift procedure in the posterior region with a simultaneous implant placement. So if we follow this surgical video, once we access the bony wall of the sinus, we start with a piezoelectric bone surgical device to do a thinning of the bone, of the buccal plate, in order to access the Schneiderian membrane. And this is done usually with this type of inserts in order to avoid some higher rate of membrane perforation that happens with drilling instruments. Then with this reverse cone insert, we start detaching the Schneiderian membrane from its bony environment, and we can also use in this case some inserts that fits more into the distal and the mesial part of the sinus, and this will allow us to detach the Schneiderian membrane in these specific parts. And then I like to use some sinus lifting curettes manually in order to go on and smoothly do a Schneiderian membrane elevation in order to access, as I told in the beginning of presentation, the palatal wall of the sinus. And as you can see, the the membrane is moving simultaneously with the breathing of the patient, which means that we have no perforation and that it is well elevated. So at that point, we start drilling in order to prepare the implant sites that will receive the two implants that we just discussed in the treatment planning. It is always important whenever we are drilling the implant that is beneath the sinus to perform an undersizing of the implant site in order to allow for implant stability, because we actually stabilizing the implant in 2 or 3 millimeters. This is why we need to have an implant site that is rather smaller than the implant diameter in order to have final stabilization. So we do place the implant in the premolar region, and once we are done with the placement of this implant, we can start filling the bone in the sinus. So the implant goes there smoothly in the first premolar region. And as you can see, that the membrane keeps going up and down with the breathing of the patient. So this is the bone. In this case, I use a xenograft. We will discuss later on the different type of biomaterials and some of the histological outcome of these biomaterials. So we fill the sinus with this xenograft, and then we place our implant. We cannot place the implant before we fill the sinus, because in this case it will be difficult to allow for placement of the bone graft in the posterior part of the sinus. So it's always important to place the bone graft first and then place our implant. And also it is important to prepare the implant site before placing the bone graft. So this is the implant that is finally placed in the sinus region, and then I allow for placing some more biomaterial in order to fill completely the sinus, to thicken a little bit the ridge, and the whole thing will be covered by a collagen membrane in order to protect that bone and to allow for proper healing. So if you see on the left of the screen, this is the radiograph with the two implants placed, and you can see the sinus elevation and the big amount of bone that was placed into the sinus, and that allowed for the placement of these two implants. And this is also on the left a radiograph with the case completed. After 6 months, this case was restored, and you can see the homogeneity of the bone graft into the sinus and the very nice outcome of these two implants in this region. Actually, one of the major complication we are confronted with as clinicians during performing our sinus lift procedures is Schneiderian membrane perforation. And if we see a review of the literature reveals that these perforation rates may vary from 11% to 56%. And some authors, like Khoury, for example, showed that half of his implant failures occurred in sinuses with perforated membranes. Also, Prusayev in 2004 showed a loss of implant survival from 100% to 69% if the membrane were perforated. This leads us to know the importance of the surgical procedure in order to avoid this potential complication, and this can be done by the use of piezoelectric surgery, like I just showed you in the case before, or by the proper selection of the cases, because there are some special anatomic features of the sinus that may lead to membrane perforation, like the presence of bony lobes or the presence of bony spicules inside of the sinus. The repair of this perforation can be done by the use of a membrane. It was described in the literature by a study by Testori, which may lead to some predictable results. If you look at this particular case, we have a sinus that is multilobular, and this is a risk factor for whenever we elevate a membrane, because it will be very difficult to desiccate it all over this special anatomy. So this is the case. We access the membrane, and when doing the elevation, effectively we have a perforation. This is why in this case we used a collagen membrane and we placed our grafting material, and this can lead to a very predictable result. And you can see the case at the before bone placement, at bone placement, and this is bone maturation, implant placement, and the finalized case. Now the question that may arise to us as clinician is, which biomaterial should we use in everyday's clinical practice whenever we're performing our sinus lift surgeries? And it's obvious that in order to have the proper answer to this question, we should know what happens exactly histologically to any grafting biomaterial we place into that sinus. I will show a couple of cases where I did some histologies, and we'll try to discuss the outcome of this biomaterial. In this particular patient, we had, as you can see, a hugely pneumatized sinus, which led to a loss of the almost totally of the residual bone height. So we end up in this case having an egg shell-like maxilla, and we see that when I perform this sinus lifting and the lifting of the membrane, how thin is the bone. So we did the grafting procedure into the sinus, and this was the radiograph before, this was the radiograph just after the surgery, and the patient had a temporary bridge over his residual teeth. And I don't know if unfortunately or fortunately this patient disappeared for 3 years, and he came back 3 years later. And to our luck, we could, in this case, while placing the implant, perform some trifine biopsies in order to try to understand what happened to the biomaterial, which was a xenograft that was grafted into that sinus. This is why we did the first biopsy and the second one. And before we try to see the histology, you can see the macroscopic appearance of this bone that looks like a very compact bone. And those are the two histologies. And if we look on a bigger magnification over this bone, you see that we have the biomaterial. This is the biomaterial, and you can see the huge amount of newly formed bone that comes and surround those biomaterials particles. You can see also here on the right side of the screen the xenograft and the newly formed bone. And if we try to compare the xenograft to the amount of newly formed bone, or to the total bone volume, we see that we have a huge amount of bone compared to this biomaterial, which means that, first of all, this biomaterial was osteoconductive because it allowed for the formation of newly formed bone, and second, this biomaterial was resorbable. And I think that those are the two main advantages that we may ask for the biomaterial we use in the sinus: osteoconductivity and resorbable biomaterial that will not lead to any inflammatory reaction or fibrosis or encapsulation. And this is what we cannot see on these histologies. And if we go to histomorphometric data on various grafting materials, this was a meta-analysis done by Henschel and co-workers in 2009. And when we correlate total bone volume to time of grafting, we see that with xenograft, total bone volume has a tendency to augment over time, while with autogenous bone, it has a tendency to diminish, because autogenous bone will resorb over time without taking or without leaving its place to newly formed bone, while xenograft or beta-tricalcium phosphate will resorb over time and will lead to newly bone formation. This is why we have a tendency to have a higher total bone volume. This is why it is one of our choices clinically today is the use of particulate grafts, not block grafts, and the use of xenograft mainly, but also in some situations, beta tricalcium phosphates or allografts. Also, in this case, you see that we had a 1 millimeter residual bone height, and this is why we did a whole grafting of the sinus with the xenograft also. And 6 months later, I retrieved a trifine biopsies, and you see the micro anatomy of this bone that is very compact, and the biopsy that shows a complete, a very nice packing of the biomaterial, and you can see that we have in some areas newly bone formation. The biomaterial in this case is still there, not like in the other case, because it was only at 6 months. And in the case I showed you before, we had more resorption because it was at 3 years. This is why we had a higher total bone volume. But also with the presence of the biomaterial, it is very well tolerated and very well handled or mixed with the natural bone. This is why this can allow us to the placement of an implant, and this implant was placed with a very high insertion torque compared to implant placed in the posterior maxilla. I had a torque of 90 Newton. I also, when I measured the primary stability of this implant, I have very high primary stability on an SQ of 85 at day 0, 83 at 6 weeks. This is why at 6 weeks I placed the final abutment that was torqued, and the impression was taken, and the final crown was placed at 6 weeks, and this is the final radiographic appearance of this implant into that bone. So, in order to conclude this first part of this presentation, I will go back to one of the most interesting reviews that was done over implant. That was the review by Wallace and Froome in 2003. And if we go back to their conclusion, we see that the survival rate of implants placed in sinuses was very high, and it was almost identical to the survival rates of implants placed in normal bone in the posterior maxilla. Another thing that is important to notice is what this review that showed that particulate graft showed higher survival rates than implants placed into block grafts. This is why also we recommend, and this is what I do clinically, to use particulate bone graft like the xenograft or the beta tricalcium phosphate or the allografts. Survival rates were higher whenever we used a membrane over the window. The inclusion of autogenous bone with the composite as a component of a composite graft did not affect implant survival. So it's not very important to mix the xenograft with autogenous bone unless we use some PRP or some PRF, for example, that can be used above the wound, and those growth factors may lead to an acceleration of the bone formation process. And finally, there was no statistical difference between implants placed immediately while grafting the sinus or delayed implant placement, considering that we can achieve a very acceptable primary stability of the implant. This is why, as I said at the beginning of this presentation, we should have a proper height of bone that should be at least, I would say, 3 millimeters in order to achieve a good primary stability of our implant.